Next topic, we have Dr. Lawrence to share with us the managing patients with ICD and the CRT implant. Dr. Lawrence is a consultant cardiologist and electrophysiologist at Covai Medical Center and Hospital in India. Dr. Lawrence, please.
Good afternoon all. I think it's afternoon back in India. My topic for discussion today would be on managing patients with ICDs and CRTs during this pandemic time. I would not call it a post-pandemic time because we are in India right now at the peak of the epidemic. I'll keep my presentation be focused on somewhat about indications, mostly about precautions and the technologies which may be of use in these patients during this period. I will try to share our own experience also during that same time. I think this slide has been already presented and I'll just concentrate on ICDs. We are going to do ICDs only when there is a secondary prevention for a cardiac arrest or a VT or VF. Our ICD is due for a replacement at a EOL level. Most of the other cases where we are planning for a primary prevention ICDs, we have to try to postpone them if possible. And most of the CRTs will be postponed to next 2-3 months period once we are set ourselves free from this pandemic period. And lead extraction we may have to do if patient is being posted for an infection control. The most of the precautions we have to take during this period during an implant, most often will end up doing either level 2 or level 3 protection. If the patient is positive, you may have to take a level 3 protection if you are going to do on these positive patients. And level 2 protection, most of our cases we may have to do with surgical caps, protection mask and working uniforms with disposable gloves and goggles. Take utmost care as possible. And to be on safer side, the personnel should be kept at minimum in the lab. Most often we end up taking level 2 or level 3 precautions. If the patient requires an intubation, better to do it outside the lab. If you feel like elective intubation you may require during the procedure, it's better to do it outside the lab rather than bringing the patient inside the lab and doing it. Keeping the procedure time at a minimum is a very important step in avoiding your exposure. Always use simpler procedures over complex procedures. If I'm able to do a single chamber ICD, I would be better off rather than doing a dual chamber ICD on all the patients. If you feel like you need a atrial channel rather than having an atrial lead in, you can have an atrial channel in. If you're planning to do a CRT, if you don't require a atrial pacing, rather than putting a CRT-D with a atrial lead, you can think about a VDX lead. This is how our lab looks like during this time. Usually our labs are reasonably crowded in back home, but during these times we keep our personnel to the minimum. One assistant along with the one tech who can take care of both our technical job and along with programming is good enough to have these many people in the lab. As I already told you, keeping the procedure time at minimum is very important. When you have fewer leads, you have fewer complications. You have fewer times that you are going to redo your job. Cutting down one lead can cut down close to 10 to 15 minutes of your lab time. Particularly in a complex atrial anatomy, if you are able to avoid atrial lead, you may save close to 15 to 20 minutes. Particularly if you have a patient with post-CABG status where you have to look around for getting a good P wave and all that. If you have a floating atrial lead, which can be positioned anywhere in the atrium, you may cut down close to 15 to 20 minutes of your time during implantation of a device. We know very well that all and more of the patient require atrial channel for enhancing diagnostic accuracy. Definitely a single chamber device, when you compare the dual chamber device, is less effective in identifying the atrial arrhythmias. Although we have a lot of algorithms already there in most of the devices, better to have a atrial channel or atrial lead inside so that they can identify the arrhythmias better way. The more and more you identify better arrhythmias, the inappropriate therapies will be limited. Particularly in these times, we don't want our patient to come to our hospital very often. Having one atrial channel in or atrial lead in will be able to avoid a lot of unnecessary inappropriate shocks to bring the patient back to hospital. So having an atrial channel is very important in these patients. When you look at these VDX leads, which have a channel in the single lead system, which have a channel in the atrial level, they have a very good accuracy in detecting the atrial high rate events compared to your dual chamber devices. It closely matches with the accuracy of a dual chamber device. You have a single lead which can do job of atrial detection. Timely detection of atrial arrhythmia prevents reduction in stroke and heart failure exacerbations. We know very well that reduction of these events is very important during these times also, because the more the patient develops cardiac arrhythmias, particularly atrial arrhythmias, the heart failure worsens, the patient presents themselves more to the hospitals, and detection early and treatment early can prevent all this. One thing we always worried from our experience from the pacemaker time, we have implanted good number of pacemakers which have a VDD kind of a lead, but the problem was always in atrial sensing. Although the atrial lead during the implantation was in a good position, atrial channel was in a good position, you are sensing a good P wave, but over a period of time, there is a significant undersensing of the atrial channel. But the good thing about this particular lead and the devices, the atrial sensing is reliable over a long period of time. We have an experience more than 1.5 to 2 years in our own patients who are doing extremely well. So where you will choose these kind of patients, whenever the patient does not require any atrial pacing, rather than having an atrial lead, have an atrial channel there, you can give all the diagnostic information you can achieve from an atrial lead. If you ask me, this is how it looks like. You have a single coil ICD lead inside with an atrial channel in. We have implanted for a patient with hypertrophic cardiomyopathy where I expected to have a cardiac atrial arrhythmias. So this looks like this, and the atrial sensor is close in the mid to high right atrial position, and patient has an excellent detection. You can see that EGMs given by the lead. You can see atrial EGMs are so clean, hardly any ventricular far field EGMs. The atrial EGMs are clean. They look like a recording from an atrial lead. You see the P waves here close to 9. This is due to amplification of P wave amplitude by these electrograms with filtering. So you can have a P waves really in a good range. Most of my VDX leads have a P waves in the range more than 7 most of the time. So having this lead extremely helpful. I use in these kind of leads, in particularly in patients with hypertrophic cardiomyopathy, where you may expect a lot of atrial arrhythmias. A lot of time we end up doing a dual chamber ICDs in these patients for the sake of identifying atrial arrhythmias. So rather than putting another lead in, particularly in a hypertrophic cardiomyopathy patient who tend to be younger, having an atrial channel is much more helpful. In patients with AICD with the indication for a complete heart block, a patient has LV dysfunction along with a complete heart block where you are planning to put a AICD in. So that is usual to have these kind of leads because you have an atrial synchronous ventricular pacing. So this is very useful in this group of patients. Any patients who have a documented atrial arrhythmia, may it be a paroxysmal or a persistent, this will definitely be more helpful rather than having a single chamber lead. So any patients who I'm planning for a single chamber ICD, rather than just putting a single chamber ICD lead, having a VDX lead will help me to further identify atrial arrhythmias, reduction in inappropriate therapy. So extremely useful. So these are the 4 situations where mostly I use these leads in my patients. So we know very well in CRT, in spite of we put an atrial lead, our atrial lead hardly paces. We tend to program our CRTs like lower rates of 60, then you may see some amount of atrial pacing. So if you keep your low rates around range of 50, which is what our targets in heart failure management, most often your atrial lead is not pacing. So in patients, most commonly you may be able to manage without a atrial lead in this group of patients. So CRTD without a atrial lead, particularly as I told you in a complex anatomy, may save you a lot of time and exposure to you and to the technical staff and to the nursing assistant. Another important thing is limit in hospital interrogation of devices. So until unless it's very important, it's better to postpone. If you have to do an MRI, you reassess your indication for an MRI. If it is not urgent, it's better to postpone during this period. And we know devices right now available which have a capability to do auto MRI detections. Particularly Biotronic has a device which can pace from the left ventricle during a period of MRI mode also, which is very useful in CRT patients. So these auto MRI devices are extremely useful in this situation because you switch on the MRI mode, the moment the device detects the MRI environment, it switches itself on. The moment patient comes out of the MRI environment, it switches itself off. So patient remains in MRI mode only during the period of MRI. And more importantly, you don't have to program the device multiple times. The patient need not come to your office, or technical staff don't have to see the patient again and again before the procedure, after the procedure, recheck the device, and all these are avoided with this auto MRI devices. So this is another important technology which may be very useful in these times. So in our hospital, we do close to 100% of our implants are MRI compatible, and more than 70% of implants in our center is auto MRI devices. So during this period, we could see that that is very useful. And when you look at our data, at least 2 to 3 patients in our device clinic group goes for MRI in a month. So you can avoid significant exposure to your technical staff, and patient can be stay in the hospital because in lesser period of time, because MRI is fixed at a period of time. You have to call the patient at a particular time, program the MRI mode on, send them back, and all that makes a lot of exposure to patient, to you, and to the technical staff. So this auto MRI mode can be very useful in this group of patients. This is ideal in current scenario, I feel. Remote monitoring, already we are going to have a talk on, and already we have a little exposure in the previous talk itself. Most often, it's always better to switch on your remote monitoring if the patient has a remote monitoring available. If you have a device which is remote monitoring compatible, better to put it on in the remote monitoring mode in present times. And if you are going to implant a device during these times, better to look at remote monitoring as a significant option, because it's very helpful for you and your patient to avoid hospital visits. To summarize, only we are going to do urgent procedures with PPA level 2 and 3. Addition of atrial channel significantly improves your inappropriate shocks and reduce hospital visits and hospital admissions. Detection of AF in early stages due to these atrial systems can avoid unnecessary admissions for heart failure and improve outcome. And integrated atrial sensing represents a significant alternative to CRT patients. If you have atrial leads, there's always, very well in a complex anatomy, there is a chance of atrial lead displacements, post-procedure, redo procedures, all these are avoided. 1 second, your procedure time is cut down close to 15 to 20 minutes in most of the cases. Limit in-person CAED interrogations until unless it's considered, and be very time sensitive. Remote monitoring has to be utilized mostly in these group of patients during this period of pandemics, which will be very good to avoid exposure to you, to the patient, and to the technical staff. Thank you for your wonderful hearing. I'll be happy if you have some questions and we can answer that. Thank you.
Thank you for your excellent presentation. And now Professor Wang will chair the discussion.
Yes, one of the audience is asking why DX is suitable for intermittent complete AV block. Dr. Lawrence, can you answer this question?
Yeah, see, these are the group of patients who have a complete AV block. Most often I will end up putting a dual chamber ICDs for the sake of atrial synchronous ventricular pacing. The only reason in complete heart block to have a atrial lead most often is to give you a atrial synchronous ventricular pacing. When you have a atrial lead which can sense extremely well and give you a good atrial sense ventricular pacing, rather than putting another atrial lead, I can use a VDX lead. So that's how the indication comes up in a patients with intermittent or permanent AV block who does not require a CRTD.